Hello, I'm a thoracic surgeon and I'm going to tell you a little bit about the surgery. You potentially have a cancer in the lung. Now all the tests you've had so far show that this is confined to the lung, if it is a cancer, and the best option of long-term cure is to remove the cancer with some of the surrounding lung. How much of that surrounding lung will be removed depends on the size and position of the cancer and how well your heart and lungs work. The exact details will be discussed with your own surgeon, but in general, the operation can be approached in two ways. One, a thoracotomy or open procedure, or alternatively two, VATS or keyhole surgery. Now in both cases, you have a general anesthetic. You're turned on your side with your arm above your head, and the airflow to the lung is stopped to allow the lung to collapse so the surgeon can perform the surgery safely. Now in the case of a thoracotomy, a cut is made in the side of the chest and the muscles are either cut or separated to allow access to the ribs. These are then separated, and in some instances we cut the rib to allow access to the lungs. Now in the case of VATS, small cuts around 2 to 5 centimeters in size are made in the side of the chest. Through one of these, a camera is passed, and through the other, instruments to perform the surgery. Now in some instances, when the diagnosis hasn't been confirmed, a small section of the lump will be sent for analysis while you're asleep. This is known as a frozen section, and depending whether this shows cancer or not, we proceed with the surgery. The amount of lung that's removed can vary between a segment just around the cancer to one or more of the lobes of the lung, known as a lobectomy, or the whole lung, known as a pneumonectomy. Where we cut and remove the lung, we usually use a staple gun to seal it. And from the stapled edge, a small amount of air and blood can leak, and therefore you have a chest drain. This is usually removed after about a few days once this settles, but occasionally you may have to go home with the chest drain. When we remove part of the lung, the remainder usually fills the space up. When we remove the whole lung, the space usually fills with fluid. And over time, the other lung expands in size to compensate. The exact approach and amount of lung to be removed will depend on your individual case, and your own surgeon will discuss this with you. I'd like to highlight a couple of other issues regarding your recovery. As I mentioned earlier, the arm is placed above the head during the procedure, and this does result in a bit of shoulder stiffness. The other thing I mentioned was that the muscles are either cut or separated to allow access to the chest. So while during the healing process, these muscles are weakened. The second point I'd like to highlight relates to the surgery. As I mentioned earlier, we collapse the lung to allow us to perform the surgery safely. And at the end of the procedure, the remainder of the lung is re-expanded. There will be small areas of collapse and retained secretions, and so it's vitally important to perform the deep breathing and coughing exercises to prevent these secretions from getting infected and developing a chest infection. So in summary, this is major surgery, and there is a small risk of serious complications. The exact nature of these, your surgeon will discuss with you in more detail.